Good afternoon. Welcome to the Epidemiology seminar. It's a great pleasure to introduce Dr. Enrique Schisterman. He is at, as you see here, the NICHD, National Institute of Child Health and Human Development. He will talk about his work in perinatal reproductive epidemiology. You will see an example of this. He is the current president of the Society for Epidemiological Research, and he is the editor-in-chief elect, if there is an election for this,
yes,
of the American Journal of Epidemiology, the prime journal in our field. So it's a great pleasure,
thank you,
Enrique, to have you here.
thank you.
Look forward to your talk on effects of folic acid and zinc supplementation on semen quality and live birth.
Thank you so much. It's always so great to be here. It feels like home, so many friends, so many people to work with. So I'm going to talk something that's really close to my heart, and I have to give you a heads up. This is unpublished work. I finished this 2 months ago, and this is the fruits of 7 years. So I'm not worried about you stealing my ideas. It will take you 7 years to finish this. But I'm really looking forward for input. We're going to try to submit the paper for publication. And any questions or comments, please interrupt me. This is a very interactive approach. So my interest has always been in the intersection between methodology and public health. And I truly believe in randomized trials. So I'm trying to look at low-cost interventions that we can apply for population. So this is an example of something that we just finished. We looked at the effect of folic acid and zinc supplementation in men, and we'll see the effects on semen parameters and live births. So as always, I will start with acknowledging my collaborators from the different institutions and my co-PI, Sunny Mumford, and my colleagues from the University of Utah, from MS, from the University of Iowa, from Northwestern, and from the Center for Reproductive Medicine in Minnesota. So, I don't know how much you know about infertility, but infertility affects approximately 7 to 15% of the couples in the U.S. Male factors contribute to infertility, and 40% of the etiology of infertility actually remains unknown. Low-cost interventions are entirely lacking for men. There are some low-cost interventions that are available for women, but for men are less common. The treatments for infertility are stressful, expensive, and frequently lack insurance coverage. You are lucky to live in a state like Massachusetts that covers infertility treatment, but this is one of the few that does that. Patients who want to get infertility treatment go to 3 different routes. The first route, what we call the first line, they do what we call IUI-OI, or intrauterine insemination or ovulation induction, and they can, and it's a procedure that has a very low success rate, 7 to 12% per cycle. Very inefficient process. That happens in 2 settings. Either if you don't have insurance, you will go to your OBGYN, and he will do an IUI-OI, will prescribe some ovulation induction drugs, and you will get the treatment. Or you could go to a fertility clinic where it will be followed more closely with some ultrasounds and a more dynamic process. If you are not able to get pregnant, or if you are diagnosed with certain conditions, you can move directly with a more invasive procedure which is called IVF, or which costs a tremendous amount of money. On average, an IVF costs approximately $12,000. It's not covered by insurance, and couples need more than one treatment to become pregnant. So it's a very, very expensive procedure not covered by insurance. So we have this array of treatments, one that it's not very expensive but tremendously inefficient, and the other one is that it's tremendously expensive and efficient but not covered by insurance. So if we can find a therapy that will help move the needle in any of these procedures, meaning couples who are going through the expensive procedure instead of having to do 2 cycles will have to do 1, or people who are going through the IUI, we find something that will be a tremendous public health impact. So dietary supplements are a potentially promising low-cost intervention with tremendous population-level health effect. The U.S. dietary supplementing industry is rapidly growing, and the FDA regulation is very, very limited. Actually, it's not in the preview of the FDA to regulate dietary supplements. Dietary supplements for male fertility are very common. They promise many, many things, from helping become pregnant to all the imaginable consequences of the supplement. So, but you can go to a supplement store and you can find those supplements with different claims. And it's a huge industry. What is lacking is proven efficacy of this treatment. They are not regulated, they are highly consumed, and so we need to prove efficacy. Folic acid and zinc are 2 target supplements that may have some biological rationale for this working. Folate is a key component of DNA production. Spermatogenesis is a process that happens daily. DNA replications for spermatogenesis is intensive, and folate plays a key role. Zinc is also a cofactor for more than 80 metalloenzymes involved in DNA transcription. And folic and zinc are also antioxidants, and the sperm is mostly, the head of the sperm is mostly nucleus, which makes the sperm especially susceptible to oxidation. So it has been shown that the sperm can be oxidized and therefore susceptible to damage. So these 2 components and these 2 cofactors may be a good target for evaluating the efficacy of this low-cost intervention. There are some trials that were done. There was a small trial where they combined, they look at placebo, they look at folic acid, they look at zinc alone, and then they look at the combination of that, and they showed that sperm concentrations were increased post-randomization in sperm concentrations, on morphology, and on total normal cell count, where folic acid alone or zinc alone did not impact the measurements. So we also look at the meta-analysis that were done in very, very small trials. 4 trials were done with these parameters, and they show all very promising results, where the folic acid and zinc improve the semen parameters concentration, morphology, and motility. But all these trials were done on less than 30 men per group. So the claims that we have, or the evidence that we have, are based on these 2 factors. So I think that this is one of the reasons where the intramural program in NIH plays a role, where we can evaluate things that the pharmaceutical industry will not be spending money on evaluating these factors. It is much better to tell you something that works than actually proving that it works. So we embark on this investigation, and the population that we're talking about is actually a very vulnerable population. What do I mean by that? Is couples who are trying to become pregnant, they will try anything to become pregnant. It's very similar. They seem to show the same stress levels that are leaving people who are going through cancer treatment. They feel very vulnerable, and they will try anything to make it work. So we believe that there was a tremendous need for proven scientific efficacy and safety of these products. So we embark on a double-blind randomized placebo-controlled trial to assess the effects of folic acid and zinc supplementation in males on semen quality, and more important, it's not enough to prove that it improves the semen quality parameters, but if you don't have a child, a take-home child, what's the point of improving the parameters if you're not going to have a kid? I mean, maybe it's a good feeling for some men, but it doesn't help the cause of what we are trying to achieve. So this will be the first trial that will look not only at the semen parameters, but actually the real outcome, which is the take-home baby. So it's a little bit of a different trial. We're randomizing men, and we're actually looking at the outcome of what will happen to the mother and child, right? So we randomized 2,370 couples, and we supplemented them with 5 milligrams of folic acid and 30 milligrams of elemental zinc, taken orally daily. And we block randomized into 3 different stratas. Number 1 is, as I said to you before, an IVF strata. The second arm will be an IUI-OI on-site done by REI people, and the third strata is done in an outside clinic. We administer 6 months of treatment, and we got visits at month 2, 4, baseline 2, 4, and 6 after randomization. And then we follow the women for another 18 months to see if they had a child or not. That's the link to the clinicaltrials.org if you want to see more details on side effects.
How many arms? 4 arms?
No, it's only 2 arms.
But you specify inclusion.
So yes, so we have a block randomized. So we have an overall trial, but also we could assess within each strata was powered to assess within each strata. So unlike other studies, we didn't use off-the-shelf formulation. We actually create our own pill. We design and manufacture the pill with the active treatment and placebo. We use 5 milligrams of folic acid and 30 milligrams of zinc. The 5 milligrams of folic acid was similar to the other studies that we find in the past. The 30 milligrams of zinc was slightly lower than what was done in other trials, and the reason is because the upper bound of limit of tolerable dose is 40. So we didn't want to go above the limit of the tolerable dose. And the other difference is that we tested continuously for stability and to ensure quality. So they deteriorate very fast, so you have to test all the time to make sure that what the capsules that you are giving these patients are exactly the dose that you are giving them. So semen quality is very hard to maintain the quality of the measurements. So one of the things we did to do that is it's very complex because it has multiple parameters and it needs to be standardized across sites. We have multiple sites. Now it's much easier to standardize across sites when you test, I don't know, let's say cytokines, because you can have a gold standard and send the gold standard to every place, and they will be remeasuring that over and over so you can maintain the quality. For semen quality, we had to develop a protocol to standardize across sites for the assessment of concentration, motility, morphology, counting a limited number of sperm which are presumed to be representative of the whole sample. So what we did is grab a big sample pool, and we measured it multiple times, and we resent it month after month after month to be retested in each location. So all the performing semen analysis were centralized and trained by a standardized lab. And what we use to ascertain the quality is what we call the Wescott Rules. I don't know if you're familiar with the Wescott Rules. It's a process that is used. I used this process 25 years ago when I was working in the industry. They use this for manufacturing. What you do is to measure the same thing over and over again. And if it comes, for example, if you measure the mean concentration of what we are repeating over and over time, and it comes out above 3 standard deviations or below 3 standard deviations, it means that, well, the chances of that happening is less than 1% by chance alone. So it's something in the process that has been decalibrated. So it's a signal that something is wrong, and you should recalibrate your process. So the machine is wrong, the temperature is wrong. So there are multiple rules. There are 12 Wescott rules. It's either 2 consecutive observations above 2 standard deviations, or 2 consecutive observations below 2 standard deviations, and so on. So this is the process we took to maintain some level of homogeneity across the sites. The primary outcomes, as I said, will be semen quality parameters, and more importantly, and uniquely here, is live birth. But we also have some secondary outcomes. We looked at ACG detected pregnancies. We looked at clinical intrauterine pregnancies, pregnancy loss, pregnancy and live birth outcomes. And in the group that did IVF, we were also lucky to look at IVF parameters, meaning how many embryos, how good the quality of this embryo, which is something that usually doesn't happen in nature. It's only in the setting of IVF that you can actually see the embryo developing and seeing how it's growing. But also it gives us the opportunity, and this is my pitch for those who are doing a dissertation, to create a big infrastructure with lots of biospecimens to test future hypotheses. For those looking for RO1s or Ks, here's your chance. Anyway, we collected blood, urine, semen, saliva, and toenails. The couple's eligibility criteria, the male-female couple had to be between 18 to 45, the female, no upper limit for the men. That's unfortunately how nature works. Couples are actively trying to conceive and seeking infertility treatment and participating in reproductive endocrinology and infertility treatments. And couples who are planning OI, or ovulation induction, or IUI, which is intrauterine insemination, or natural fertility, willing to be taking the study supplement for 3 weeks before they started their fertility treatment. We wanted to have a run period where it takes 72 days for sperm to mature, so we wanted the folic acid to have enough time and the zinc to have enough time to have an effect. The female partners, the exclusion criteria is the men can consent. If the female didn't consent, we didn't randomize them. And if they were using any other partner to do, any other external force to become pregnant, we didn't use them either, or we didn't, they were excluded. The male exclusion criteria, of course, I'm willing to abstain from use of non-study approved supplements containing folic acid or zinc. They were also if they were diagnosed with vitamin B12 deficiency, because folic acid can mask vitamin B12 deficiency, so, or anemia at screening, non-vitamin B12 deficiency within 5 years that has not been successfully treated, consuming a vegan diet, genetic causes of male factors, so fertility, including chromosomal disorders related to subfertility, concurrent use of any drugs that affect either the metabolism of folic acid or zinc, history of treated infertility, and of course all the common comorbidities. So they couldn't have chronic diseases, including heart disease, diabetes, hypertension, cancer, and more. Crohn's diseases, celiac diseases, and a long list of other conditions that were not included. Of course, a history of alcohol and drug dependency disorders, and history of diseases and symptoms that require folic acid supplementation. So the protocol, as always, we take a one shot, right? This is our one shot, like the nurse says. You do as much as you can with the time we have with them. So this is a very intensive protocol. They came at baseline. We took a safety questionnaire, evaluated safety questionnaires, medical review. We obtained biospecimens. We did a food frequency questionnaire and anthropometrics. They were randomized to treatment or placebo, and we also took a daily journal. And then they had to come back at months 2, 4, and 6. And then the overall flow participants also, the female had to have a baseline questionnaire, and she has to fulfill a baseline, a monthly questionnaire every month, and the men have to come for visits as well. So as you can see, it's a very, very intensive questionnaire, a very, very intensive protocol, and the outcomes were either there were an array of ways to ascertain the outcomes, including medical charts, abstractions, self-report, verified by charts, and so on. The analysis of the primary outcomes was an intent to treat. We did live births and semen quality comparisons at 6 months, and we looked at the usual suspects. We also did a very, which ended up being a difficult analysis, because we looked at HCG detected pregnancies, which are hard to ascertain and standardize. We did the clinical intrauterine pregnancies. We looked at early pregnancy losses, less than 20 weeks of gestation, and stillbirths. And then we looked at all the reproductive outcomes: preeclampsia and gestational hypertension, gestational diabetes, cesarean deliveries, preterm delivery and gestational age, small for gestational age and birth weight, chromosomal and structural abnormalities, which was one of the hypotheses that this may improve the presence of chromosomal and structural abnormalities, and serious maternal and neonatal morbidity and mortality. And of course, as I said before, embryo parameters, which is another unique aspect of this trial that we were able to see. Okay, so to do a trial, you need to do an interim analysis many times. So we had the DSMB who was composed by 2 epidemiologists, 2 statisticians, 2 MFM, and 2 REIs, and a chair who was just somebody from NICHD blinded to us who will take notes. And they will meet regularly to see all the adverse events and to conduct an interim analysis. After 50% of the data was collected, they determined that they wanted to do an interim analysis on sperm concentration, sperm morphology, and sperm motility, not on live birth. And the analysis was done blinded completely to us by the Data Coordinating Center, and it was a one-sided t-test for harm, and the boundary of that test was minus 3.04. And they calculated after that the spent alpha, and I will explain a little bit for those who are interested, was 0.012. So we spent very little of the alpha, which means from now on, all the confidence intervals that I will be showing are actually 95.1, not 95%. Okay, so it says 95%, it's actually 95.1. So there's a little bit more conservative. But we had to do that interim analysis. We wanted to make sure that this is safe. So here's the boundary, is 3.04. So to be crossing the boundary, you have to have a value that it's above that number. And you can see that for our concentration, we didn't see that cross the boundary. For morphology, did not cross the boundary. And for motility, did not cross the boundary, either by the complete case analysis or by imputing. They used two approaches, and they found similar results. Now, which we got a memo, very nice memo, and says you can continue recruiting people. So which is a very tense day. You don't know what to see that day. It's a very tense day. So we crossed that boundary. Okay. So also we had some loss to follow-up on the trial, and we did some sensitivity analysis to account for the loss to follow-up. One of the approaches that we use is inverse probability weighting, where we predicted the probability of stopping or loss to follow-up by different factors. And I will present some of the analysis, although it didn't make much difference in the results. But that's there as well. Some of the results. Ta-da-dun, ta-dun. Okay, so for the recruitment, we were able, as I said, we recruited for 4 years, from 2013 to 2017, and then we followed them up for another year. The goal was to recruit 2,400, and we recruited 2,370. We went 1 year longer than we were supposed to go. So it wasn't easy to recruit the couples. It was 4 clinics. 4 clinics. I show you the baseline characteristics because not that there is something to be told about the characteristics, but it's because I love trials. And this is the magic of the trials. On average, you have this pseudo-person in these 2 groups that are identical. And it's amazing how this works. When the sample size is large enough, randomization works. We should use that more. It's a wonderful tool. So you can see that in the treatment arm and the placebo arm, the male age and female age were equivalent, BMIs, and so on. The primary outcomes. So overall, what do you think we found? Well, first we can see that IVF is a more efficient way to get pregnant, which is already known. But overall we found no effect whatsoever. We see a risk ratio of 0.98 and a risk difference of minus 0.76, so no effect whatsoever. Not on the IVF arm, not on the non-IVF arm, and not on the non-IVF offsite. Okay, so let's see how this was translated to folic acid and zinc in the semen parameters. And you can see that also between the folic acid and zinc concentrations, there are no differences either on concentration, motility, and morphology. There was actually harm associated with DNA fragmentation. That is, so the number, this number is what's the percentage of fragmented. The higher the number is, the worse it is. So there's a 2.5% fragmented, that it's more on the treatment arm compared to the placebo arm. Now, luckily, it didn't translate into pregnancy outcomes, right? There is some harm that is not associated with a reduction of live birth on this trial, but we saw a harmful, small harmful effect.
So that was just a 1-year follow-up, right? For the pregnancy.
The pregnancies after you finish 6 months of treatment, and we follow them up for 18 months.
18 months.
Okay? Okay, and then you will say, well, maybe this was affected by selection bias, but by the loss to follow-up, we did a reweighted analysis using inverse probability weighting, and results did not change. So I'm still working on it, but it doesn't mean that, to me for now, it doesn't show that the loss to follow-up could explain these findings. So a little bit of harm on the semen parameters based on this. Secondary outcomes. So we could see that maybe it didn't affect live births, but maybe some of the events that happened before could be affected by it. Let me see how I'm doing with time. Okay. So the couple-based approach, ACG pregnancies, there were no differences. Clinical pregnancies, no differences. Any indication of pregnancy, no differences. No in preeclampsia, GDM, cesarean. We see an increase of preterm birth. Now, either by relative risk or risk differences. But I will tell you that I actually am less confident about this result, because there is no really biological rationale, number one, for why would it affect only preterm birth alone and nothing else. And secondly, because there is a sensitivity of the point. When I do a cut point analysis at 37 weeks, there is a protection protection before and a harm after. So when you look at this, which is the effect on gestational age, we don't see any effect on gestational age. You would have expected that if you see a preterm birth effect, the median gestational age by treatment and placebo be different. And we don't see anything. We also don't see any effect on birth weight, which is how is it translated into the baby. But it's something that should be considered and should further be studied. Okay. Embryo parameters. So here's when we get to the fertilization rate is exactly the same. Number of embryos, of good quality embryos at date 5, exactly the same. We didn't say anything on those parameters. So, safety outcomes. And what I mean by safety is, you will see. Because safety means that, have a preterm birth, one could consider is not a safety parameter. So I mean slightly different. So ectopic pregnancies, early pregnancy loss, stillbirths, neonatal mortality, structural malformations and chromosomal malformations, we don't see anything. Now, these are hard to see anyway in a trial of this magnitude. I will not be able to see any of the effects. We will never be powered to see effects here. But if there is something extremely extreme, we will. So we didn't see that here. Now, also we want to see what are the adverse events in men, in the men who are taking this treatment. So there is no serious adverse event. Serious adverse event is defined an adverse event that requires hospitalization. So they were equivalent or slightly higher on the treatment arm, but there is a great increase of a known side effect of this treatment. It is known that it will bring abdominal discomfort and pain. It is known that it will bring nausea and vomiting, and nausea and vomiting. So if it would have worked, it's something that people could sustain, but it's not working, and they're going through all this with no benefit, right? There's also a little bit of a rash, so discussion, yes, and I don't think we can say that based on our data, and I'm not sure this will ever done again. This is the thing about these trials that we can recommend for general infertility population. There are more adverse events. There is no improvement in semen parameter, in semen quality parameter. If nothing else, there is some detriment. And there is no improvement on the primary outcome, which is live births. Nothing. Look at if it could be explained by dropouts, and we did an analysis, and we can show that although there is dropout across the 6 months, it's not explained by women who got pregnant. It's not explained by the treatment itself. It's not explained by those who did not get pregnant. So that's not the reason. And we did the reweighted analysis to try to account for that, and that does not explain as well. Now, this is crude, and I will apologize for that. I'm not at the point to do a compliance adjustment analysis, meaning we actually weighted the bottles to see how many pills each one took. And also we have a self-report. So the analysis of self-report shows that between the treatment and placebo across the time is equivalent. It is possible that there is one group was less compliant and it will not adjust. But the intent to treat remains the same regardless of that. So, in conclusion, this idea that these supplements, you could take it because it will do not harm, right? That's the idea. That's what doctor said. Just if it doesn't help, it will not do any harm. This is not maybe not true, and in our trial is showing that there is some harm associated with taking these supplements. And there is also besides the lack of efficacy, there is potential side effects that can now be communicated based on these results. I will go back, and I don't know if I'm the right person to be saying this, but this relatively unregulated supplemented industry, it could be potentially harmful. So this idea that we have two standards, one for supplements and one for pharmaceuticals, is something that maybe needs to be explored. At best, this is not an efficacious male fertility supplement causing GI problems. And there is a broader potential message for the widespread dietary supplemented use and regulation. I think there is a point to be talked about that. However, the initial thought here is that we still need for a safe and affordable option to improve fertility outcomes. We need to keep looking into this. We can't abandon, because of these trials, this array of possible low-cost interventions that will help us will achieve that goal. And if nothing else, we may be able to look in the future. Maybe there are some groups that may benefit from it. the different DNA fragmentation thresholds, and there is novel biomarkers and clinical markers. So besides those results, we end up with the largest ever done randomized trial of couples seeking infertility treatment. And there is a lot of the collection of longitudinal semen analysis, so we will be able to answer some questions about standardization and how semen progresses over time. And there's a lot of opportunities. So if I could push the plug again and say if anybody is looking for some data in this realm, here's an opportunity. With that, I want to thank again my collaborators and co-authors on this paper, and I'd be happy to take any questions, and thank you for having me.
Thank you very much. I knew about a take-home message or a take-home exam. Take-home child is a new one. We have questions.
Yes, Carmen. Yes. Yes. Okay. So that's a great question, but remember this is a randomized trial. So in essence, if randomization works and may not work because it's post-randomization, they should be balanced at baseline with respect to any factor that you measure or did not measure. It is possible that over time these factors have changed, but they're unlikely that have changed due to the folic acid and zinc that was given to the men. So, no, we didn't at this point. As I said, maybe there may be a group that in the future we can assess that may benefit from this. But at this point overall, on a randomized trial as this, would not be the case. Yes.
Yes, please. So, Enrique, I'm going to take your views. I'm making 4 questions in one.
Okay.
One about the design of the trial.
Yes.
One about
Maybe two.
Okay, perfect. So, first, of the design of the trial, the dose you use for folic acid is the same dose that was used in the Dutch trial. But most of the products in the market that make claims about fertility use much lower doses. They use either 400 micrograms or 800 micrograms. So why 5 milligrams why 5 milligrams when most of the market have a much different dose? And when you're in a population that is vastly different to the Dutch population in terms of fortification, and also regarding the design, did you do the same thing that it was in the which they showed that there's an effect if you're oligospermic at baseline, but there's no effect of the folic acid vaccine combination if you're normospermic at baseline. Do you see any of that? And about my second question.
No, we have more questions. So
Okay, so yeah, and you can call me on we can talk about that later. Number one is that if it wasn't going to work for the Dutch, we saw something on the Dutch population, then we wouldn't going to see anything in lower dose. So we went to something feeling that's the safest bet we have. Number two was
Baseline semen quality.
yes. So the approach is not to, at this point, was not to personalize. We wanted to see if we do this in a large trial where we can use it for all, it will work. It is possible, and as I said, that we will find a group that this is effective. By the way, I did a preliminary analysis that it's not. But yes, maybe.
So, for diet trials, obviously, one is concerned with baseline levels, and I'm wondering if you tried to reconcile the previous trials where the meta-analysis did show benefit. Now in the U.S., because of fortification, low folate is very rare. It used to be very common, now it's very rare. And I'm wondering if the trials were in a pre-fortification era or countries that didn't fortify. Maybe Folic does work, but now that part of the problem is solved. Possibly.
Yes, that's a great question, except that the trials were not post-fortification in the U.S. There are countries that is still not fortified, but is not. And the dose that is recommended right now is so much lower. It's 400 micrograms compared to 5 milligrams. So we really gave them a high dose. So we were thinking that the group that we're observing will benefit from a much higher dose. It's a great question. I don't know the answer to that, to be honest. This is what we did.
Enrique, that was an excellent talk. I was especially impressed by the fact that you recruited so many people in 4 or 5 years. We've been trying to recruit people in our city for a long time and haven't reached those numbers, but it's only one clinic. So I think that was a huge success story of your project, and I think that there's lots of benefits to future use of your work, of your data. The question I had related to Jorge's a little bit in the sense that whether or not there's a benefit to certain subgroups, which I think you alluded to in the last part of your talk. And in particular, I'm thinking about the different causes of infertility and whether or not certain subgroups of causes might benefit. And I think Myra said the same thing, was whether or not above and beyond a certain threshold, will certain groups actually benefit versus the group in itself, the whole group may not have benefited from that food.
Right.
And so could you comment a little bit on that?
Yes, yes.
The other question was the severity of infertility. I don't know if that was accounted for at all. So
Yes.
people had much longer time to pregnancy, may have benefited more or less, and people had less time, I think.
Yes.
So that was something that you
You listed a lot of questions and
Yeah, no, that's fine, that's fine. That's fine. So, look,
that's a good sign.
I will say this. First of all, you have to remember the rules of a trial and the frequentist approach. You have to pick one hypothesis, one test, and design your trial to answer one question. Anything that I do afterwards, such as stratified analysis by this and by that, I'm spending my alpha. So there is a potential of type 1 error. To start with, I want to try to see if it's going to benefit the most amount of people. It is possible if I did a targeted trial to certain group, I will benefit on that group the most. Then what do I do with the consequences of that? It will be used for everybody else, regardless of the evidence we have. So we went with a more target population-based approach that will be wider to the public, show if it's working, because there is a biological rationale for it. It may not be exactly the biological rationale for everyone, but the sample size was large enough to try to answer that overall question on an heterogeneous group. You could say, Carmen, if I find tomorrow in a subgroup analysis of this, you will say, well, we need to design a new trial to test that hypothesis with the right alpha and the right power to do that. But, yeah, yes, Frank.
I'm curious whether the animal models showing that what you guys did with Zinc can actually improve semen quality.
They did.
Animal models
Yes.
strong biological.
Yes. That's the heartbreaking.
So that's a mouse model, a rat model, which may not apply to humans.
Yes, it may be that it does not apply to. And there are, the semen parameters is not also, that was the big leap of faith that we are coming with time. When I started the trial today, we're coming to the realization that all these semen parameters are actually not really good predictors of live births. So you can, as I said, you can end up having wonderful semen parameters and not being able to conceive. So.
Any final questions? Well, yes. Grace, Chan,
Thanks for
please.
that talk. I just had a question about, do you think there's a dose response effect of folic acid on these outcomes? For example, could there be no effect at 5 milligrams, but there could have been an effect somewhere between 400 micrograms and the 5 milligrams? And are you able to measure the folic acid level concentration between the two groups prior to supplementation and then during the course of the study?
Yes. So these are questions that we will look. To be honest, my guess is that I don't expect that if I don't see anything with high doses that I will see something with lower doses. But that's my guess in that regard. We will be looking into subgroups and see if this will work for some. But again, once we start that direction, it's not really a randomized trial anymore in a pure sense of a randomized trial. The alpha has been spent. This will be a secondary analysis. We'll find something. It may not be confounded, but it's still not. It could, the likelihood of type 1 error increases as we do more and more tests. You can have multiple treatments. It's the cumulative, yes. So one life, yes.
Richard.
You're going to close it out. So, thinking really big picture, I'm
Yeah.
curious what your thoughts are on your role specifically in terms of the advocacy piece around supplementation and the FDA. I mean, we have just a couple of examples, including folks here like Bryn Austin, who are doing some really nice look at health advocacy on that front. But I'm just curious what you think your role might be in that.
I have to be honest, so I'm going to pour my heart out here and say that I'm completely disappointed. I did not expect this. So I'm to terms with the realization that this is the finding of the trial, and I have to be thinking about this. So I haven't formed a form opinion on how to advocate appropriately for the right use of supplements with enough evidence to support it. But it's important. It is important. So thank you. Thanks, everybody.
Thank you very, very much. And I invite you, not next week, but in 2 weeks for the next seminar, which will be Professor Jamie Robbins.
Nice. And come to SCR.